Kia ora koutou. It's a great pleasure for me to be here today. I appreciate the invitation. As you'll see, where I'm planning to head has got quite a deep intersection with what you're talking about today, localism. I'd acknowledge Minister Ducey, but I don't think he's here. I would like to acknowledge many colleagues, prior and current, too many to identify personally. Otherwise, that would take me half an hour. I have unfortunately not been that well, and as a result of that, I received a vocal cord injury. And my sort of first prize for me is just lasting the distance when I'm giving a speech or a talk. And it just reminded me of something David Longi once said. I was fortunate enough to meet and know David Longi reasonably well because of his association with Middlemore when I was chief executive out at South Auckland Health. And I don't know if all of his stories were true or if they were slightly apocryphal, but they were always brilliant to listen to. But when I started having trouble with my voice, which I'm a few weeks away, I understand from it being fully recovered, I was reminded of a story that David Longi once told. He was giving a speech to an audience of maybe 1,000 people. This was at the time of the nuclear issues for which he became, quite famous. And he said he was giving this talk, and, unlike me, he's got an extremely loud voice. But he was about 20 minutes into his talk, which he thought was quite an exciting talk, when he just got the sense that the audience couldn't hear him, that sometimes happens. And because he had such a loud voice, he stood back from the microphone and he said in his very loud voice, "I don't think the sound system is working very well, and I just want to check right at the back in the corner there. There's a man with a shiny bald head and a bright red bow tie. Can you hear what I'm saying?" And he said this person stood up and in the clearest, loudest voice said, "I can hear what you're saying perfectly, Prime Minister Longi, and I'm very happy to exchange with somebody who can't. So I won't be checking out whether you can hear me or not." So you always know when your job is extremely challenging, and I should recognize and acknowledge Rob Campbell in the audience, Chancellor of my university, in fact, and who was the initial chair of Health New Zealand Te Whatu. You always know that the job that you're taking on is going to be extremely challenging when the messages that you get when you're appointed are 90% commiseration and 10% rather weak congratulations. So this is not a job for the faint-hearted, and I thought I would start by sharing with you why I took this job on in the first place. There are three reasons, really. The first is I believe New Zealanders are waiting far too long for essential health services. I believe that the safest wait is the shortest wait, and your disease doesn't go on pause if you have to wait for a service. And we know that there will always be waiting in a large health system like ours and any others, but I strongly believe that the waiting times are a critical issue, an urgent issue, and that is the number one reason why I took on this job. Reversing that is not going to be simple, but it has to be an absolute priority. New Zealanders need and deserve a lot better. We have waiting times that are designated, and most of those now are not being met, and there's a big delta between where we are and where we need to be. So that's a massive challenge and an urgent challenge, and that's the number one priority for the organisation. The second reason, and I know that there might even be eye rolling on this in this audience, but I believe very strongly that more health services can be delivered within the existing resources. Productivity is not a word that is often used in any health discussion, and often it's a word deliberately denied in these discussions. I don't regard productivity as simply a commercial construct or economic construct or financial construct. I regard productivity as a clinical construct, because very simply, If you can do more within your resources, sometimes it might have to be at a marginal cost, but if you can do more within your resources, you'll be able to help more New Zealanders get the health services they need. And I know that we often think mainly about emergency department waiting times and waiting times for the first specialist appointment, which, by the way, we've got 170,000 people waiting more than 4 months. Or waiting times for elective surgery. By the way, we've got about 65,000 people waiting more than 4 months. The focus is often on those services and also faster cancer treatment times. But I believe every waiting time should be reduced. You may be approached in your ward and told you're being discharged today, and you might have to wait around hours and hours before it happened. You may not be able to get a general practitioner appointment when you need it. You may have to wait for an inordinate amount of time for all sorts of things. The whole organization needs to become much more responsive, needs to speed up. And it's not where the organization has been, but it's where the organization needs to get to. And that movement isn't going to be easy. I know that myself. Health systems are complex adaptive systems. And as a result, they are not deterministic or linear, and they don't respond in the way lots of other organizations respond. You know, in a lot of organizations, you could pull a lever and get a response. In healthcare, you can pull all the levers you like, and you're likely to get all the responses you didn't want. Okay, it's a different kind of organization, and that is why you cannot take the same approach to managing a large health system or health organization that might be relevant if you're running a bank or an energy company. And it's not that we're all in a battle here to have the biggest challenge or the hardest organization to manage. Myself, I would love it if it was simple. I would love it if it was linear. I would love it if it was a lean, mean health delivery machine. But it's not. And that's the reality. Excuse me. The second reason I took on this role, the third reason I took on this role is I believe every single contact that anyone has with Health New Zealand Te Whatu Ora should be compassionate and caring and considerate. And thankfully, the majority of them are, but there are some that aren't. Sometimes they're only moderately compassionate, and sometimes they're not compassionate at all. When people come to our organization, they are vulnerable, they are stressed, they're in difficulty, and we should be unburdening them rather than placing more burden on them. And this is a huge cultural change. And I've just recently written a book chapter on the impact of digital health on compassion in health systems. And in doing that, I did a deeper read into compassion in general. And it is degrading in all health systems, and there's many reasons for that. But we should not accept any of those. You know, we should expect that no matter what the situation is, everyone who has contact with Health New Zealand Te Whatu Ora is treated in a compassionate way. Our job is to unburden people, not burden them. So that's the three reasons: getting waiting times down, getting productivity up, and treating everybody every time with compassion and care. That's the reason I took on the job. But when you actually get under the hood, there's a lot of other issues going on. The organization has a deep financial crisis, losing on a monthly run rate deficit about $135, $140 million a month. This loss materialized in 1 month. I don't actually believe that, looking into how this actually happened. But if you extrapolate that out for the year, we'll be in a $1.4 billion deficit at the end of this financial year in July of next year, and that's just simply unacceptable. So we've got a massive financial problem to resolve, but that is a sideshow to the main show in town, which is waiting times, productivity, and also compassion and care. So how are we going to do this? Well, first of all, I believe the organization needs a hard reset. I believe the direction needs to change, and it will change. Key elements to the change are devolution of decision making. So we are moving to a regional and local model. It's not 4 new organizations, it's 1 organization. This is a both and, it's not an ideological thing, it's a logical thing. So where it's sensible to be 1 organization, we will be. And where it's sensible and logical to be regional, we will be. And as we move down the track of this, it'll be where it's sensible and logic to be local, it will be. We will go down as far as we can. So devolution, we've appointed 4 new deputy chief executives of each of these regions, and they are given matching authority and accountability and at a high level, and we expect them to shift that down. We want people to be able to make the decisions at the local level as much as possible. The point about this is, will everyone make the best possible decision? Well, probably not. But we'll rather take the risk of moving this direction than what is a much bigger risk in staying with the centralized model. The second critical part of the reset is a level of clinical involvement and engagement that hasn't been seen in New Zealand previously. That's a commitment I've made. It's a commitment that I intend to keep. I would like all the critical decisions to be made in a clinical frame of reference. And I'll give you just a recent example. I learned of something on Saturday that has been around for a few years. It's been dealt with as an infrastructure issue, and reasonably well in that regard. But this is not an infrastructure issue in my view. This is a clinical safety issue, should have been led by clinicians and supported by infrastructure. Recruitment of staff, I think it should be led by the appropriate professional group and supported by people and capability. So what I see in this organization is, in many ways, and this could be an overstatement, and I'm happy to rethink it, but I think the marrow has been sucked out of the line into the support functions within our organization are called enabling functions. And I think they're too strong. I think they have too much influence and sway over what happens. So those are 2 critical elements. They will make a difference because what you can probably see is, I believe that Health New Zealand Te Whatu was over-focused on what I call the hardware of the organization, institutional arrangements, structures, funding models. And what I'm trying to do is a shift to what I call the software of the organization, leadership, culture, operating models, service to patients. So it is a big shift. It is a big shift in culture, and I expect that it's going to be really quite challenging. Why would I even want to go down this route? And this is where the intersection is of this direction and what you're talking about today. Is in complex adaptive systems like healthcare, you can only really enhance performance if you can tap into local social capital and local knowledge. You will never get the innovation that we desperately need and are looking for if everything is top down. So this is quite a reversal. We're going for a bottom up, and getting as close to the local as possible, because we need to unshackle the local social capital and local knowledge if we're to move this organization forward. And this is really important because local social capital and local knowledge is typically composite or tacit. It's not very easy to access. Okay, you're not going to access this even if you're able to develop quite good relationships at a distance. It has to be proximate, not distal. And this is why what I'm doing here isn't an ideology. It's not really just like my idea. This is an application of empirical knowledge that is well researched. And why don't we just stop making it up and look it up? Because we do so little on objective empirical evidence, and we do things on just what we feel like or what we think might be the way to do things. So I think that this will work. I think it's going to be quite a hard road. And yeah, right at the moment, It's not that easy in the organization. You only have to read an article that is coming out today to see that it's not that easy to achieve what I'm trying to achieve. But we will make changes in order to get to the place that we really want to get to. I think that everyone's got different perspectives about healthcare, and we have overcomplicated it, actually. And we have fallen so far behind, in areas that we should be ahead. And digital is one of those. When you look at the two major headwinds that we face in healthcare, funding and workforce, which is kind of a universal issue, I cannot think of any other way than digital to not completely solve this, but to help us solve this problem. And I think we're quite far behind in New Zealand on the digital and exponential health opportunities that lie before us. And one of the reasons for that is we are so stuck to sunk costs. Okay, the sunk cost fallacy, that just because you have invested a lot of money into something, you should keep investing it. I just really don't understand this. And I saw a really good example of this when I was in the UK a few years ago, where they moved to specialisms. And I went to meet two hospitals, and they had both specialized in cardiac surgery and oncology, cancer. And they had decided to split that. And one would do the cancer and one would do the cardiology and cardiac surgery. And I asked them, what did you do about sunk costs? And the answer I got, if you're going to worry about sunk costs, you're never going to make any progress. And in reality, it is quite hard to walk away from sunk costs, legacy systems, legacy investments. But they're called legacy systems and legacy investments for a reason, actually. We have to be strong enough, tough enough to actually break some of these umbilical cords that we have, tear down some of these Berlin walls that we have, because a health system that is truly a system has got shared aims and objectives, and it has a combined operating model, and it has boundaries that are porous, and it has multiple interdependencies and manifold areas of control. Rob Hennon said that when we started, I hope we can work together. Well, what I'm proposing is a combined operating model, independent of ownership. We should have an operating model that we share. Some of the services we will fund and provide, some we will fund and not provide, some we will neither fund and not provide. It doesn't matter about any of that. We should be smart enough, mature enough to actually develop what New Zealand needs, which is a health system, not a series or a sort of agglomeration of various health structures. So primary care is an area that I'm targeting as a priority. And primary care's problem is that primary care is dependent, I guess, on current funding models and can't make a break from those. Primary care always says what it can do, but never gets a chance to actually do it. So I'm going to change that. I cannot change the funding contour within the whole of Health New Zealand to Whatu at a whim. I need evidence. So we will do pilots and trials with general practice, and if they can do what they say, and we can prove that, then we'll change the funding landscape, because that's in the best interest of New Zealanders, and we would do that. But I need evidence. So if primary care says that we could reduce the admissions of people over 65 into hospital by 50%, and if we could prove that, which they believe they can, and actually I believe they can too, then we've got a reason to change the funding. So we will have to defund and refund. Okay, it's not going to be simple. Okay, I don't worry about winners and losers. You might think that's naive. I only worry about patients, families, and communities. Those are the only people I'm interested in being winners. Everything else that we do in the end has to be done on some basis of fairness, but in the reality, we will do what is right for patients. I have said that as long as it's legal and ethical, I will do whatever I have to do to deliver to patients, families and communities what they need and deserve. I just wanted to talk about the workforce issue because it is a very important issue. But the discussion about it is often uncontested. Okay, you'll hear about a shortage, and of course there's shortages, and you hear about difficulties. We cannot generalize the anecdote to change the whole system. So what I'm trying to do is get hard data and follow up all the soft intel to try and get a clearer picture. Because if people feel there's a problem, then there most likely is. So what I have done is I have commissioned, and we're partway through this, a snapshot review of the clinical quality and safety of Te Whatu, because I have no idea. And that is being done by leading clinicians within our organisation in conjunction with Health Quality and Safety Commission and the Health Roundtable in Australia. And once we know that, we want to try bring in the data from the soft intel and work out exactly what the problems are. Because health systems are addicted to treating symptoms and not problems, and we're trying to break that addiction. So we need to find out what the problems are and actually address them. But I think that the conversation about workforce and the effort into workforce is needed and it's necessary. But I'm not sure that the discussion is a complete discussion. It's asymmetrical. We talk about workforce, but we don't talk about work in the same way. We need to examine the work. We need to examine the resource utilization and the effectiveness of the work. And we need to look at all of our models, and we need to look at how professional groups work and how they could work differently. Because we have got big gaps. The interesting thing about Health New Zealand Te Whatu is never before has there been so much money. Never before have there been so many full-time equivalents. But the lift in outputs and outcomes, whichever way you look at it, is not commensurate at all. So for example, in the last 12 years, our case-weighted discharges, which is a measurement in healthcare that takes into account acuity so that these comparisons are reasonable, our case weights have increased 2% per annum. Our workforce has increased 3.4% an annum. And if you just look at the last 2 years, it has increased about 4.5% per annum. Now, people still feel as if it's difficult and the environment isn't a good one necessary to work in. So this is a paradox because you've got two conflicting elements that are both true but seem to be somewhat mutually exclusive. I think we need to examine this paradox much more carefully and actually try to resolve it, because we want to create a rewarding environment for all of our staff to work in, not an environment that is difficult. Look, there's elements of healthcare that you will never be able to change. Not everyone who comes into the organization behaves in the way that everyone would like, and we have to deal with those things. So I guess that we're going to try and move as quickly as we can. You know, the cliched, this is not a marathon, this is not a sprint, it's a marathon. Well, for us, I'm afraid, this is a sprint and not a marathon. We don't have time. Okay, John F. Kennedy once said, you need to fix a roof while the sun is still shining. Well, the sun has almost gone down for us. We have got a narrow window to actually sort this out in a way that is reasonable, practical, and that everyone gets value out of that. The patients, the families, the communities, all of the wonderful people who work in our organizations, and the taxpayers of this country. The taxpayers of this country should get value for money. We need their money. This is primarily a tax taxpayer-funded health system, but there should be value for that. And right at the moment, I don't believe that that can be evidenced. So we go on this journey. We start with the devolution and the clinical involvement. We have got significant changes to make to the organization, its size, its structure, not all of which will be painless. And that's a heartbreaking situation to be in, but I didn't cause the situation. Unfortunately, I need to fix the situation. But we have to face some very strong medicine as an organization. We have to live within our means, and we will. So for us, the key element is to get waiting times down in all elements of our healthcare, including now mental health, which I think is an excellent thing. And in order to do that, we need to make sure that we have an environment where patients get high quality and it's safe, where our staff, visitors and patients, where the workplace environment is safe. We need to make sure there's compassion in the system. We need to be productive, and we need to focus on where we can spend our money best, which is going to be on the essential elements, such as the asset condition of our facilities, our technology, on cybersecurity, the places we have the biggest risk. But we have to rationalize. We cannot continue to do everything. In my humble view, Health New Zealand Te Whatu Ora has got so many priorities, it's got no priorities at all. We are going to have very clear priorities. We're going to bring focus into the organization. We're going to bring discipline into the organization, and we will change whatever needs to be changed in order to deliver these low waiting times to patients, families, and communities, and productivity. And that's a pretty simple formula, pretty challenging environment. I wouldn't have taken this on if I wasn't committed. My wife has said, when you talk about committed, what type of committed are you actually talking about? And it is interesting, a good friend of mine, when I was taking on this role, said, Debbie, my wife, said, she won't let you do it because you're always doing these crazy jobs. And when I spoke to her, she said, you know what, 2 years ago, I would have said, no way. But we've had, unfortunately, a lot of illness and accidents in our family. So my father-in-law, my mother, my wife herself, my granddaughter, we've had a lot of problems and been in our hospitals a lot. And she said, after our experience, I will carry you there on my own back. You will have every support that you need. This needs to be fixed. And so, I mean, it might be scary to have to respond to the Prime Minister, the Minister of Finance, and the Minister of Health, but nothing is more scary than my own wife holding me to account for the health system. And I love her and respect her, and I'm going to make sure I keep it that way, because she's holding me to account, which is a different type of accountability. So thank you for listening. If you just wonder how you do this job, I am reminded of what Winston Churchill said. If you really want to get to your destination, you cannot stop and throw a stone at every barking dog. I just need to know which dogs matter, and I just need to know that whatever happens, on the good days, on the bad days, I am going to resolutely lead this organization to this destination. I cannot do it by myself. I need all the help I can get, and so far I'm getting a lot of that. So I'm not a religious person, but if you are, please pray for me. Thank you.